This is Lecture 26, Immunodeficiency Diseases. In this lecture, we're going to be looking at the immune deficiencies of our B cells, T cells, the combined B and T cells, and defects in the neutrophil function. We also will identify secondary immune deficiencies. This can be due to another disorder or a particular treatment that the patient is receiving and causing these primary immune deficiencies. And then we'll discuss laboratory techniques that we can do in order to help us detect or diagnose these diseases. So when we talk about our immunodeficiency disorders, these disorders are caused by defects in certain components of our immune system, whether it be cellular immunity or our humoral immunity. So this all goes back again to our first lecture that we had when we were talking about our natural and acquired immunity. So remember, our natural immunity is our phagocytes and our complement, and our acquired immunity has to do with our T and B cells. So remember, without our natural immunity and them processing these antigens to display to our B and T cells, then you could see what potential issues that we could have going further with our immunity to certain antigens, certain diseases, or viruses. So when we look at our immune system as a whole, we have to understand that all of these components of our immune system have to interact with each other. We can't have one without the other. We can't have our acquired immunity without our natural immunity, and vice versa. So all these systems interact with each other, and a defect in one system typically will cause hyperactivity of another system, trying to compensate for this lack of this one action that we are missing. So in this case, we could have persistent infections continuously over and over because we cannot either produce an antibody to this certain type of infection, or if it's due to regulatory control, if we're overproducing an antibody or something to that nature, then we have a defect in like a plasma cell or a B, somewhere in the B cell line. So all these things we have to, all these components, they have to interact, and they have to be talking to each other per se in order to help regulate this immune system reaction and to help us defeat this infection or viral infection or whatever we're trying to overcome. One thing I'd like to briefly mention in the previous slide is that we have partial immunodeficiency states. These could be due to allergens or autoimmune diseases. So somebody has autoimmune disease, then potentially we could have a what we call a secondary immunodeficiency syndrome as well. So let's briefly talk about our primary immunodeficiency syndromes. Now, all these syndromes we'll be talking about are relatively rare. The one exception would be IgA deficiency. That is actually more common. We'll also be talking about X-linked inheritance. So X-linked meaning these affect primarily males, and some are autosomal recessive, so that means we need a defective gene from our mother and a defective gene from our father in order to have this immunodeficiency syndrome. But the overall common denominator here when we talk about immunodeficiency syndromes is that most patients present with recurrent infections. They can never get over a cold or some type of bacterial infection, and that is the primary symptom that these patients do present with. And here is a chart of the outline process from our stem cell to our plasma cells in our B cell line and our cytotoxic T, suppressor T, and helper T cells through our T cell line or maturation process. There is another diagram, not of this, but a different diagram in your books on page 328. I find this diagram a little bit more pleasing to the eye and a little bit easier to follow, so this is why I'm using this one. So we'll kind of work our way through as we go through these different syndromes or immunodeficiencies, and you can see by the letters in blocks A, B, C, D, and P, those are the 5 different deficiencies we'll be covering, and these deficiencies obviously affect either a B cell or T cell or both at different processes in the maturation process. So we'll be talking over these in the next few slides. Let's first look at deficiencies or primary deficiencies of our B cells. So when we think of B cells, obviously we think of antibody producing cells. Obviously our B cells will differentiate into plasma cells, and our plasma cells will start to produce antibodies. Well, in AGAMMAGLOBULINEMIA, our bodies are not producing enough antibodies or any antibodies to specific antigens. Now this could be potentially due to we have a defect in where the B cell is not proliferating into plasma cells, alright, or we could have a total breakdown of the B cell when it's actually transforming from a stem cell into a B cell and it's just not fully engaging or fully maturing into a B cell. So there are a lot of different possibilities of why these antibodies are not being created. We could have humoral immunity defects, so typically these will cause pyogenic bacterial infections, specifically in the upper and lower respiratory tract. Typically viral infections ail them about the same as normal individuals, meaning they really they can fight off these viral infections because T cells will actually plays a major part in viral infections. And a lot of these primary deficiencies in our B cells can be due to genetic defects in either, remember, B cell maturation or the communications between the T and B cells. Our B cells provide us with antibodies, so our antibody levels vary with our age, okay, in normal individuals. So at birth, we'll have low levels of IgA and IgM that the baby's immune system is producing, but we'll have a lot of IgG as well because of our mother, which passed this on past IgG, her IgG antibodies to us. All right, 2 to 3 months will go by and the IgG usually drops, all right, because we'll be metabolizing the mom's IgG antibodies. And so as the age progresses, the baby will start to produce its own IgM, IgG, and IgA levels. And as we grow older, these antibody levels will increase. You will not need to know these reference ranges for the exam. I just have them on here so we can kind of get an idea of the ranges from birth to 18 years and older of the different Ig levels for each antibody, IgG, IgA, and IgM. So the first syndrome we're going to talk about is transient hypogammaglobulinemia of the infancy. So why infants get this, we still don't exactly know. They have normal CD19 B cells, and this condition does not appear to be X-linked, although it is more common in males. Cause may be related to a delayed maturation of one or more components of the immune system, and possibly due to the delayed maturation of the T helper cells is what we theorize. So in this transient hypogammaglobulinemia, we have prolonged low Ig levels. The infant has reoccurring affections, but after 9 to 15 months of age, their Ig levels will usually normalize and go back to normal, and this transient hypogammaglobulinemia will usually disappear or fade away. So it is very interesting, especially because we don't know why this disease occurs. So more research is going into this, and I do look forward to seeing, what the researchers find in this. The first primary immunodeficiency that is on our chart is X-linked Bruton's agammaglobulinemia, and this is obviously linked to the chromosome X, so it's almost seen exclusively in males. Alright, so in this particular disease or immunodeficiency, our T cells will be completely normal, so we have adequate normal T cells, functioning T cells, but the development of the pro-B cell stage to the pre-B cell stage is blocked. So that means we have, in this immunodeficiency, have no classes of IgG or Ig whatsoever, so we have no antibodies. And it's because of a deficiency in an enzyme called Bruton's tyrosine kinase. And this deficiency is from the failure of the variable H gene rearrangement. So if you go back to one of our previous lectures when we're going through the gene rearrangement process in the B cell maturation, this variable gene does not get added. So this is what causes this X-linked Bruton's agammaglobulinemia. Here's our chart, our diagram. So we can see that the B is circled for Bruton's. This is X-linked Bruton's agammaglobulinemia. And anything after that B to the right, the B lymphocyte, plasma cell, and antibody, patients with this particular disease do not create those. So we have our lymphoid stem cell. It gets stimulated to become a B cell. Then it'll turn into a pre-B cell, and then it stops. It cannot mature any past that pre-B cell stage. So therefore, these patients do not have mature B cells. So therefore, they don't have plasma cells, and therefore they cannot produce antibodies. So this is a huge limiting factor with this disease, is that they cannot routinely fight off bacterial infection, so they have recurrent infections all the time. Usually patients with Bruton's are first discovered when they're children. They typically will have recurrent otitis, cellulitis in the diaper area, and a lot of organisms that are cultured from these different regions include Pseudomonas aeruginosa and Staph aureus. Also, a lot of patients commonly develop sinopulmonary infections, mainly from strep or Haemophilus influenza. So how can we differentiate X-linked Bruton's from transient hypogammaglobulinemia? Well, if we have persistence beyond 2 years of age, then we typically know that it's probably Bruton's, or this X-linked Bruton's, because usually transient will resolve itself after the first 1.5 years of life. All right. So if somebody is diagnosed with Bruton's or X-linked Bruton's agammaglobulinemia, what is the treatment? So they will have to get regular injections of antibodies, usually intramuscular or intravenously on the regular. They will need this for the rest of their lives, and obviously you would think that, and you're correct to think that this would get very expensive. And plus the antibiotics, if they do come down with an infection, they have to take a very strict and highly dosed of antibiotics to keep that infection down. So the next one is IgA deficiency. Alright, so remember, this is the most common type of primary immunodeficiency that we see. Typically, most patients are asymptomatic, so they really don't know that they are IgA deficient. Usually, anti-IgA antibodies are produced by some patients, and usually the way they find this out is through if they have a blood transfusion. We could treat this with antibiotics as needed, but other than that, there is really no other treatment for this IgA deficiency. So why do you think we cannot treat this with IgA therapy? Well, for one reason is that IgA has a half-life of 7 days. So I mean, you'd have to be going getting shots every week for your natural life, all right, and that just wouldn't be cost effective. Also, if we where are these IgA, our typical IgA antibodies found? Usually in our mucosal regions of our bodies, right? So if we get IgA therapy intravenously, well, they're never going to make it to our mucosal systems. One reason, the main reason, is we may develop anti-IgA antibodies and therefore cause anaphylaxis within our bodies. So this is why IgA therapy is highly not recommended. Usually we'll just treat the infection with antibiotics. The next immunodeficiency on our chart is common variable immunodeficiency, or CVI, and patients with this immunodeficiency have a normal number of B cells, all right, but these B cells can't differentiate into plasma cells and therefore produce antibodies. And there's quite a few reasons why that they cannot differentiate into plasma cells, and we'll talk about those in just a moment. So usually patients who have CVI are usually in their 20s and 30s, and a lot of patients will present with malabsorption and diarrhea, other malignancies, and possibly autoimmune disorders, mainly hypogammaglobulinemia, obviously, because they are not producing any antibodies, and they are usually IgA and IgG deficient. All right. So typically, how we diagnose CVI is obviously the patient will have a low serum IgG with recurrent bacterial infections. Obviously, recurrent bacterial infections is key in pretty much any immunodeficiency that we will talk about today. So how can we treat CVI? These patients will get IVIG injections and treat with antibiotics as needed. So here's our diagram again. So our C represents CVI, or common variable immunodeficiency. Now remember that these patients have a normal number of mature B cells. They just can't differentiate into plasma cells. And some reasons for this potentially could be that the T cells or their products appear to suppress the differentiation of B cells into plasma cells. All right, that is one theory. And secondly, T cells may fail to provide adequate help to support terminal differentiation of the B cells, and or it could be that just a primary defect in the B cell line in some patients cause these B cells not to differentiate into plasma cells. So there are a couple of different reasonings why this type of immunodeficiency can come about, but either way, these patients will have to get intravenous or intramuscular injections of IgGs, and potentially more likely antibiotics if they come down with a severe or moderate infection. Let's talk about the B-cell deficiencies we went over. So we talked about transient hypogammaglobulinemia. Remember, this is in infants before they reach the age of 2 typically. They'll have low levels of antibodies in their immune system, and as they grow older and hit the age of 2, a year and a half or 2 years of age, usually this transient hypogammaglobulinemia will subside and they will regain normal levels of IgGs or antibodies in their immune system. We also talked about X-linked Bruton's agammaglobulinemia. So remember, in the B-cell maturation process, the stem cell will get stimulated and it'll turn into a pro-B cell, and then from the pro-B cell to the pre-B cell, it gets stopped due to the deficiency in Bruton's tyrosine kinase. So it cannot produce any mature B cells or plasma cells, and therefore no antibodies. And remember, it is X-linked, so it's almost exclusively in males. We also have IgA deficiency, which is one of the most common B-cell deficiencies. Usually people first find out that they are IgA deficient is when they get a transfusion. They'll usually have transfusion anaphylaxis. And the last one we talked about is CVI, or common variable immunodeficiency. And usually they will have mature B cells, but they cannot produce, these B cells can't differentiate into plasma cells and therefore make antibodies. We looked at the B-cell deficiencies or humoral deficiencies. Now let's kind of turn our sights on the cellular immunity aspect of these deficiencies, or T-cell deficiencies. So we see a lot of recurrent infections, obviously, with any type of immunity deficiencies. We will see recurrent infections with either intracellular pathogens, including fungi, viruses. Candida is a very big cause of these infections with T-cell deficiencies, and we'll also see an increase in malignancy as well. Just like with our B-cell deficiencies, we could have defects at the different stages of the T-cell maturation process, and as you can figure, that this could potentially affect the humoral immunity as well, because they interact with each other. When we talk about cellular immunity deficiencies, one of the biggest issues with somebody that has this T-cell deficiency or cellular immunity deficiency is that they are very difficult to manage. They just can't get a shot of antibodies, to help them fight this disease or this deficiency. They actually have to go through a bone marrow transplant most of the time in order to help them recover from this deficiency. And that leads to other gigantic issues, one of them being graft versus host disease. We'll briefly go over this in later lectures, but basically it's when the donor cells will start to attack the recipient's tissue. Alright, in order to prevent this, we can do irradiation of the bone marrow or transplant or the blood products, whatever we're giving to the patient. But graft versus host disease is a common problem when we do bone marrow transplants. That's the main thing we are worried about. The first deficiency we'll talk about is DIGEORGE anomaly. DIGEORGE anomaly is a developmental abnormality of the third and fourth pharyngeal pouches. This ultimately affects the thymus and a variety of different organs in the embryo development. If you do not know what pharyngeal pouches are, so these are some structures that include the middle ear cavity, palatine tonsils, the thymus, parathyroid glands, etc., that develop in the neck region, and this ultimately what develops into helps develop the thymus. So people with DIGEORGE anomaly are missing a portion of the chromosome 22 on the Q11 region of chromosome 22. So if they do not have development of the thymus, if we think back to our T-cell maturation process, what does that mean? Well, that's where T-cells go to mature, right? So if they don't have a thymus that's been developed, then they are not able to produce mature T-cells. So this is a big deal, especially when it comes to viruses and fungi and trying to help control these type of infections. Now there is a partial DIGEORGE where they have near normal immune system, so they still do have some mature T cells, but they are not able to supply the body with a sufficient number of these mature T cells because of this DIGEORGE anomaly, this partial DIGEORGE anomaly. Some treatment, typically they will, if they're young enough, they'll go through a fetal thymus transplant, especially if maybe they one of their siblings, they were born at the same time and didn't survive delivery, then they could do a fetal thymus transplant at that time, or a bone marrow transplant. That's another common treatment for DIGEORGE anomaly, and also thymic hormones as well to help stimulate the thymus. So here's our handy dandy chart. So D represents DIGEORGE anomaly, so obviously this is at the thymus region and it's going to affect the whole line of T cells. The next deficiency we will be talking about is the purine-nucleoside phosphorylase deficiency, or PNP. So PNP deficiency is a rare autosomal recessive trait in which it usually presents in infancy with recurrent infections, chronic infections. We could also see oral and cutaneous candidiasis or candida infections, skin infections, UTIs, and typically failure to thrive. So PNP deficiency affects an enzyme involved in the metabolism of purines, and it's the number of T cells progressively decrease because of the accumulation of this deoxyguanosine triphosphate, which is a toxic purine metabolite. Alright, typically the humoral immunity is fine. Usually it does not affect the humoral immunity. One thing to note also is that when infants are showing these symptoms or these signs, remember the number of T cells have or are decreased, that PNP deficiency can be confused with neonatal HIV infection because they kind of show the same symptoms. We would obviously have to run a HIV test to rule out neonatal HIV. So here is our diagram, P meaning PNP deficiency, and we can see that it affects the T cells as a whole, and will have a heavy decrease in T cell numbers. So let's do a summary of our cellular immunity deficiencies. So remember, in these cellular immunity deficiencies that we'll be seeing a lot of intracellular pathogen infections, including viruses and fungi. Typically, Candida is the most likely candidate, no pun intended, to these intracellular pathogen problems. So these deficiencies include DIGEORGE syndrome, which the thymus is heavily affected. We have PURINE-NUCLEOSIDE phosphorylase deficiency, or PNP, where toxic purine products cause a decrease in T cells because they are not able to mature and differentiate into the different T cells that our body needs to help fight off these intracellular pathogens. So now let's look at the combined cellular and humoral deficiencies. So as you would guess, in these deficiencies, we would have both a defect in the T and B maturation process, and or a defect in the interaction between the T and B cells. And this is, as you can imagine, probably the most serious type of deficiency one could have. So this brings us to The Bubble Boy. Not Jake Gyllenhaal's The Bubble Boy movie, but David Vedder. David Vedder was born in 1971 to David and Carol Vedder. They previously had a son before David who died at 7 months of age due to SCIDs, or severe combined immunodeficiency. So that child had no immune system whatsoever, just like David. After their loss of their first son, the doctors did let them know that if they did conceive any more male children, that there was a 50% chance that the child would have SCIDs. So a few years later, they conceived and David was born in 1971. The doctors were aware of his condition before he came out of the womb, so they prepared a special chamber for him. So as soon as he was born, they put him into this chamber in that way to protect him from all the germs, etc., from the outside environment. And this is where he lived for 12 years. And they knew that the only possible cure for this would be a bone marrow transplant, but they could not find a credible match for his bone marrow. So he came famous by NASA. NASA created him a suit where he could actually walk outside and explore the outside surroundings. And I believe he was 12 years old when they decided to do a bone marrow transplant from his sister bone marrow. So they extracted bone marrow from his sister and put it into David Vedder, and ultimately his body didn't reject the transplant, but they did not catch the Epstein-Barr virus that was hiding in his sister's bone marrow, and that ultimately developed into Burkitt's lymphoma and killed David Vedder. He was 12 years old. So this is just one instance of SCIDs, this severe combined immunodeficiency syndrome. SCID. So what is SCIDs? Severe combined immunodeficiency. So obviously this is the most serious type of immune deficiency that we know of. It has a variety of different defects. So what is SCID? So basically it is a mutation in the interleukin-2 receptor gene located on the X chromosome. This is the most common form of this disease, and it is basically makes up 46% of the US cases. So if you think back to our cytokine lectures, what is interleukin-2? So interleukin-2 is that growth cytokine, right? So if these growth receptors are not functioning properly, then we cannot have differentiation and growth of our T cells and B cells and NK cells, etc. Alright, so it halts maturation. Now, there are other variety of other defects that are grouped under SCIDs, including autosomal recessive SCIDs, when the child inherits 2 defective copies one from each parent. This used to be formerly known as Swiss type AGAMMAGLOBULINEMia, and it's been found in areas where they like to keep it all in the family, basically. So family mating that has been going on. Also, adenosine deaminase or ADA deficiency. Alright, so ADA deficiency is similar in the PNP deficiency, where ADA deficiency has toxic metabolites of purines accumulate in the lymphoid cells and impair the proliferation of both B and T cells. So when somebody has ADA deficiency, the immunodeficiency directly correlates with the degree of the ADA deficiency. So basically, patients with only a mildly reduced ADA activity may only have a slight impairment of their immune function. So it's kind of, if you have a severe ADA deficiency, then you're going to have a severe, you're going to be severely immunocompetent or immunodeficient. Sorry. So let's take a look at this on our diagram. So A represents ADA deficiency or adenosine deaminase deficiency, and obviously this type of deficiency is a double whammy in that it stops the B cell and T cell maturation process. Another combined immunodeficiency is the Westcott-Aldrich syndrome, or WAS. So WAS is a rare X-linked recessive syndrome that is characteristically referred to as the triad. Alright, so we'll have immunodeficiency, eczema, and thrombocytopenia typically. Now, there are abnormalities in both the cellular and humoral branches of the immune system, generally related to a defect in antigen processing. So if you think about, okay, well, if there's an issue with antigen processing, then these B and T cells they don't know what to look for, right? They can't proliferate and differentiate. As a result, Patients typically display a severe deficiency of the naturally occurring IgM antibodies to ABO blood groups, or our isohemoagglutinin. This is pretty much a diagnostic of this disease. So the low levels of IgM are a very excellent characteristic of this disease, because typically the patients will have normal IgGs and maybe slightly increased levels of IgE, but their IgM levels are markedly decreased. And usually this disease is lethal in childhood, typically due to infections, hemorrhaging, and or malignancy. The only current treatment for this Westcott-Aldrich syndrome is bone marrow transplant, or possibly cord blood stem cells from an HLA identical sibling. The next syndrome is ATAXIA-TELANGIECTASIA. So ATAXIA-TELANGIECTASIA is a rare autosomal recessive syndrome, usually characterized by cerebellar ataxia and telangiectasia. So cerebellar ataxia, or ataxia in general, is involuntary muscle movements, and telangiectasia is the capillary swelling, usually resulting in red blotches on the skin. When a patient has ataxia telangiectasia, typically we'll see this capillary dilation in the earlobes or in the eyes, are the most common. So this disease is from abnormal genes that's produced a combined defect of both the humoral and cellular immunities. All right, so we'll typically see the number of circulating T cells is often decreased in these patients. And these patients with AT have a defect in a gene that is essential to the recombination process for genes in the immunoglobulin family. So basically, the arrangement of the TCR and immunoglobulin genes just does not occur normally in patients with ATAXIA-TELANGIECTASIA. So let's go ahead and do the summary of our B&T cell deficiencies. So obviously we have severe combined immunodeficiency, or SCIDs. Remember, it is X-linked, and adenosine deaminase deficiency is a severe combined immunodeficiency that is the most common type of SCIDs. Westcott-Aldrich syndrome, or WAS, is also a X-linked protein defect, and typically in WAS syndrome, we are not making IgM antibodies to our blood group antigens. ATAXIA-TELANGIECTASIA is a defect in the Ig and TCR gene recombination process. So we're not able to make certain types of antibodies, and our T cell receptors are having issues in that recombination process as well. So let's move on to our defective neutrophils, our other classification. So obviously our neutrophils, all right, these are like our first line of defense against infections, right? So these are involved in antibody-mediated killing. They perform phagocytosis, so they help ingest or kill extracellular organisms that's in our bodies that are trying to invade our bodies. And if there is an issue with any part of these neutrophils trying to perform their duty or their job, then we will obviously see a recurrent bacterial infections in patients who have this defect in their neutrophils. So remember, at the beginning of the course we talked about the process of how neutrophils get to the inflammatory area, or react with the inflammatory response. So our neutrophils are lined in our blood vessels, waiting to be called to a certain area. And once they get these chemokines from this inflammatory response, right, they'll go through diapedesis, which they'll squeeze through the cell membrane from the blood vessel and out into our tissue, and then start to engulf microorganisms or whatever is causing that inflammatory response. Now, we could have defects at any one of these stages. So we could have where our neutrophils don't adhere to our blood vessel walls. We could have where they cannot go through diapedesis, they can't squeeze through the blood capillaries into the tissue. We could have where a defect in that maybe they can engulf the bacteria, but they can't digest it. So there are different defects that can affect the neutrophil stage of the job of the neutrophil. So the first defect in neutrophils we're going to talk about is the chronic granulomatous disease, or CGD. Now, this diagram shows a normal, phagocyte. Alright, so it'll engulf the bacterium into the phagosome, create a phagolysosome, and these lysosomes will start to digest that bacteria, and then it will excrete the soluble debris through exocytosis. Well, in chronic granulomatous disease, it has a defect in killing the microorganisms, so that we have an issue with the lysosomes. So they are not killing these bacterial pathogens. And obviously, if that is the case, then we're going to have recurrent infections because we cannot get rid of that bacterial infection. Typically, if children are diagnosed early enough, we can do granulocyte transfusions or cytokine administration, and possibly even bone marrow transplants to help correct this disease. If it's not diagnosed, typically the child will succumb to this disease, typically by way of infection. The next deficiency is myeloperoxidase deficiency, or MPO, and this is due to some genetic abnormalities. This is one of the most common types of neutrophil abnormality. Generally, it does not cause any issues in the patient. The most common issue that we do see when people have myeloperoxidase deficiency is that they have an increase. They are increasingly susceptible to candidiasis or Candida albicans, or yeast infections, basically. So there's really no treatment for this. Most people will live healthy, normal lives, but they just have to watch out for the candidiasis, and especially diabetics or already more susceptible to candidiasis. And if they have myeloperoxidase deficiency, they even have to be more vigilant about this. And the last one is leukocyte adhesion molecule deficiency. So, like I kind of stated previously, the neutrophils cannot adhere to the walls of our endothelial cells. Alright, so this causes abnormal adhesion, motility, endocytosis, and chemotaxis. So what this means for the patient is they'll have chronic skin infections, delayed wound healing because the PMNs or the neutrophils can't get to the area quick enough, and the infection will get out of hand or out of control real fast due to this delayed reaction of the neutrophils. So a quick summary of our neutrophil defects. We have chronic granulomatous disease, or CGD. Remember, this is the neutrophil cannot kill the ingested organism, so it can ingest them into the phagosome and the phagolysosome, but they cannot actually kill them with the lysosomes that they are producing. Myeloperoxidase deficiency, typically these patients will have recurrent candida infections. Usually there's no treatment available for this. They just have to treat the infection. Leukocyte adhesion molecule deficiency, so these neutrophils cannot adhere to the walls of our blood vessels, making them able to quickly respond to an inflammatory response in our tissues, so it takes them longer to respond, and ultimately the infection could get out of control quickly without a quick response from our neutrophils. So let's take a few slides and kind of look at our secondary immune deficiency. So this is an abnormality due to another disease or treatment that we may be getting. So one of the most common types, or an example of this secondary immune deficiency, would be someone who has who developed Hodgkin's disease, and then because of their low their immune system is suppressed from this Hodgkin's disease, that the herpes zoster virus will show up and they'll start to get shingles, etc. So this is the herpes zoster would be a secondary immune deficiency. This is just another example. A lot of HIV patients will come down with CRYPTOCOCCUS neoformans because of, remember, their CD4 cells are so low that, and we need these T cells in order to fight off fungi. CRYPTOCOCCUS will typically rear its head, and usually HIV patients will succumb to this CRYPTOCOCCUS neoformans. So there are a lot of other secondary immune deficiencies. We can go over burns, diabetes mellitus, malnutrition. If you're having a surgical procedure, or even with aging, alcoholic cirrhosis, immunosuppressive agents, corticosteroids, radiation if you're going through chemotherapy. So there are a lot of these processes that can actually lower your immune system and cause you to develop another disorder. So what can we do in the laboratory to help evaluate these deficiencies? So obviously, no matter what we are doing, we want to run controls, which are obviously very critical in our line of work. We can do screening tests. So the first test I would perform with no matter what we are looking at would be a CBC and differential count. We can then further that into looking at the humoral immunity as a whole. We can measure our serum Ig levels. Another thing would to measure our isohemagglutinin. We can look at our IgG response to certain proteins. We can look at our cell-mediated immunity, so we can do hypersensitivity skin tests, phagocyte defects. So if we are thinking that we have our neutrophils, some type of defect with our neutrophils, we can look at that. Also complement, so total complement activity and its components, we can always look at that to see if these complement components are being used up, or maybe they are not being used up when we have an infection, and that could lead us to think, okay, maybe there's something wrong with our antibody production. So all these things we need to consider as we are looking at our patient results when we think that they possibly might have an immunodeficiency. This table kind of helps break down different tests we can do if we suspect if this patient has a humoral immunity disorder or cell-mediated or maybe a neutrophil defect. We can run these different types of tests to help us detect if this is exactly what's going on. We can also do confirmatory testing with flow cytometry, and that would allow us to help us enumerate our B cells and our types of T cells. Here's a quick review. If you'll fill in those blanks, we'll go over those in the next slide. Start our thymus, we have our DIGEORGE anomaly that affects our T cells. Alright, so if we have an issue, a defect in our thymus, then obviously that's going to affect our T cells. Next is our PNP. This is our PURINE-NUCLEOSIDE phosphorylase deficiency, and it's an enzyme that involves the metabolism of purine, so we have an enzymatic deficiency in this PNP deficiency. Next would be the ADA, that is our adenosine deaminase deficiency. Alright, so this would be part of the severe combined immunodeficiency because it affects both our B cells and T cells. Then we have our BRUTON'S or X-linked BRUTON'S tyrosine kinase. Alright. And then we have CVI, or common variable immunodeficiency. So here I have provided you with a immunodeficiency summary, that everything that we talked about today. You can use this to help you study. I would use this in conjunction with the notes and textbook to get other information about these deficiencies and defects as well. And this is the end of lecture 26. In the next lecture we will start to go over hypersensitivity.